Hello, everyone, and welcome to the most exciting PCI case of the past year webinar from the Cardiovascular Innovations. Thank you all for joining us tonight. This is the first webinar for this year, and we look forward to lots of learning. We have a CME accreditation for this that you can claim going to the CVI Solutions website. And we have a tremendous faculty with us today, Dr. Chadi Alraies from Detroit, Dr. Lorenzo Azzalini from the University of Washington in Seattle, and Dr. Katherine Kunkel from the Piedmont Heart Institute in Atlanta, and the disclosures are all listed on the slides. As I mentioned before, you can have the CME at the end of the meeting, and we would like to thank our sponsors, which are Abbott Laboratories, Medtronic, and Shockwave. And this is the link. Again, if you go to CVI Innovations website, you can find it. And let me remind everyone for the CVI 2024 meeting, July 18 to 20, it's back in Denver. It's going to be much better weather, much cooler, and we look forward to a lot of great science with TED-style talks and a lot of interaction. So again, would love to get started. We'll go alphabetically this year, so to some extent. So we'll start with Dr. Alraies. So Chadi, thanks again for being with us today, and we look forward to discussing with your cases.
Thank you so much, Dr. Barlakis, for the invitation. Really delighted to be here. The title is very interesting, and I think hopefully we'll come up with some interesting point of them from these cases. I have no disclosures. So this is a very interesting 29-year-old man presented with 1 week history of nausea and vomiting. When he presented to the emergency department, he has stated that he's trying to get detox from his chronic use of Xanax. His blood pressure is 128/90, heart rate 110. Lab were unremarkable except some AKI, and eventually troponin came back positive. Elevated at more than 5,000. This is a high sensitivity troponin. Because of these findings, and because he never complained any chest pain, that's triggered the EKG, the 12-lead EKG. As you can see there is a very remarkable ST elevation, almost diffuse everywhere. You can argue that this is can be pericarditis, but you cannot ignore that this is J-point elevation, suggesting true ST elevation, and mainly of precordial and lateral lead. Because of these findings, the patient was given aspirin and loaded with ticagrelor, and the STEMI pager was activated to bring the patient to the cath lab.
And just curious, Chadi, would anyone, Katherine or Lorenzo, would any of you just hold tight on this patient and do an echo or do some more interactions, or would you just be uniformly agreeing of just bringing the patient to the cath lab?
I have a really low threshold to cath these patients. I think a diagnostic radial catheterization costs you very little. Even if the diagnosis ultimately ends up being Takotsubo or something like that, you can make the diagnosis really fast and reassure everyone. And I just find that these can kind of be like a nail-biting, white-knuckle moment, just sitting in the unit. Should I do them? Should I not? I just personally prefer to just knock it out.
Yeah, there's no question that this patient should get a cath. The main question may be treated like a STEMI, or do some kind of workup. Like maybe you can do an echocardiogram in the ER while you're waiting for the cath lab team to go to come in. But yeah, it doesn't look too reassuring to me. So probably I would have cath this patient urgently, if not emergently.
It's funny you mentioned that, because the way it was mentioned, I was driving back home on Sunday morning after finishing round, and they said, we have this guy, we don't know what's going on, take a look at his EKG. So I drove back and saw him. He just was throwing up. He wasn't complaining of chest pain, but the EKG was concerning enough, as Katherine mentioned. Maybe just take him and take a look. So the course kind of deteriorated from there right away. As we're pushing him to the cath lab, the patient became very hypoxic, agitated, and they intubated him in the emergency room. From there, he went into VFib, cardiac arrest, CPR for 2 cycles, shocked 2 times, and loaded with epinephrine and levo as we're transferring him to the cath lab table. And that's kind of led us that this is most likely a true cardiac event leading to his troponin elevation and the ST changes. We saw it there. So this is the angiogram, as you see from the left side. We have an epicardial view showing left main is fine, but there is a a big filling defect involving the LAD, especially the proximal segment, very long, a thrombotic lesion most likely, and the most likely differential, as well as TIMI-1 flow not even reaching the mid LAD. The circumflex, as you see there, or the high OM, as you see it there as well, is not filling well, and there is definitely a filling defect. Because of this heavy thrombus burden, he was already receiving heparin. We bolused him with tirofiban, which is our 2p3N inhibitor in the cath lab. And from there, as you see, the arteries are very smooth. I couldn't tell if there is a plaque rupture, especially for somebody 29 and with this diffuse disease. Of note, the RCA shot before this and is showing completely open RCA. So we start to balloon, and we're daughtering mainly the wire and eventually ballooning to get some flow into the LAD. And the patient during that episode, he has multiple runs of VFib requiring shock to bring him back. Again, more ballooning. I tried to protect also the circumflex/OM just to make sure that there is no retrograde dislodgement of this heavy clot backward to the left main. So I just tried to protect the circumflex and the OM with the wire, but also make sure to get some flow to the distal circumflex.
And just curious, Chadi, so again, obviously great management of patients with this. Just curious, would people sometimes go with a penumbra or some sort of aspiration when you have this massive amount of clot, or you think it's unlikely to be able to retrieve it given the size and the location? And plus, there's the risk of stroke when you're coming back to get clot thrown into the aorta.
Yeah, I think it's a relevant point, Manus, particularly in a patient like this one that we think he doesn't have any ruptured plaque, maybe it's just embolic, so it's better probably to suck it out entirely. Another question that I would like to pose to Chadi is that, I mean, this guy was on 2 pressors before the procedure, and there is a huge thrombotic burden. There is high risk of no reflow. Any thought about putting a MCS device, for example, Impella up front or during the case?
It's a very good point. As you know, from the door to unload trials, and in terms of patient with shock, definitely this is a shock patient, and we don't know, as of now, we don't know what's his EF and what's his LV-EDP. Definitely, or argue can go ahead. But the fact that he was coding, and because of the finding of the angiogram, I was worried as to kind of get some flow and eventually transitioned. When I get some flow, I'm going to go ahead and put MCS on him. But I was still puzzled at this point to why this patient had this heavy clots. Where is it coming from? What's the source? Unlikely to be for somebody 29. And he admitted that he's taking Xanax, but he did not admit for any cocaine. And I never seen a cocaine that caused that much of clot. To Manu's point, thrombectomy, as you mentioned, and there is a comment also in the chat box talking about, would you do thrombectomy from the beginning before ballooning? With the concern that Manus mentioned of the stroke, especially the TASTE trial and other trials, that I just did ballooning, and eventually I had no choice but to go with thrombectomy. And this is the CAT-RX, continuous thrombectomy, aspiration thrombectomy catheter. So it doesn't lose negative pressure. It can maintain minus 29 or minus 30 throughout the aspiration. As you advance it over the 014 wire all the way distal, and you pull it out as you are aspirating all the way until you come out from the guide. And for sure,
Yeah.
we aspirated a good amount of clots.
You know, I would say with the penumbra, I wish I could say that was my end all be all catheter, that I really could get a lot of organized clot out. But I just find that, especially, the clot that you showed was so large and organized. I just feel like up front, I would be pessimistic that a penumbra would make a huge difference on that. And I actually feel like sometimes I'll do 3 or 4 passes of penumbra, get really not very much, and go to export. Go back to old school. I don't know if other operators have that experience, kind of failing with penumbra and then making some progress with export.
Well, export, you can go 7 friends, right? So the advantage is you can actually get a bigger one if you have a 7 friends guide. Now, this seems to be radial, so you might be a little more limited in the size, but I agree with you. And the other option is to also use potentially guide extension, deep engage it inside the coronary artery, and then try to aspirate through the TUI. And sometimes you can get some big clots out like that. But I agree, there's no perfect solution for this large thrombi. And what I've done a couple times, which again always makes me nervous, is take this device made for brain thrombectomy that it's actually like metallic, it's nitinol meshes. You put them in and then you deploy them and the clot gets trapped and you pull it out. But I always get a little nervous because you might dislodge something which could then travel and cause other problems. So there are some solutions, inside the box and out of the box, but it's always a big challenge.
100%. And just to continue with this aspiration findings, as once we're done aspirating, we found that, as you see the left side, the LAD start to get some flow all the way to the apex, but definitely the OM, large OM, is still kind of very slow flow and the clot's still there. I did not do a thrombectomy on that vessel itself. So in order to understand the mechanism, and I know maybe this is not the right time to do imaging, but I just wanted to understand, is this something I need to stent? Is there a plaque rupture? Again, he's 29, unlikely to have a CAD. So I did perform IVUS, and you see it there on the pullback from the LAD on the right side of the panel. That's point. You see there's nothing really, any atherosclerotic disease, and just kind of remaining clots in the vessel, confirming that this mechanism most likely is a thromboembolic event or acute coronary thrombosis more than a plaque rupture. Now, just to confirm, again, going to Lorenzo points is about the mechanical support. Giving I did some hemodynamics, so we did a right heart cath, and you can see there's almost like a Takotsubo phenomena with a completely akinetic apex. And you cannot argue, I cannot tell from this angiogram personally, but maybe there is some akinesis and possibly mural thrombus laying down in the LV. ADP was 42, MAP was 60, RA was 21, and wedge pressure was 27. Cardiac output was 2.9, and the index 1.7 on levo, levo and epi, and SVR 1100, CPO 0.5, and PAPI 0.7. So with these hemodynamics, we are reassured that this is somebody need mechanical support, and another thing is going to make it without it. With the fact that there's a concern about the LV thrombus, I was hesitant to put an Impella there because this is a black box warning in this situation. Anybody has any thoughts about what to do next and about these hemodynamics?
Well, I mean, the LV thrombus issue can be solved with a bedside echo in less than 5 minutes. I think this patient definitely needs support left-sided first. And, while keeping him in the lab after like half an hour or so, repeat the right heart cath, see if the RV catches up. If not, you might need also right-sided support. At that point, you might argue Impella RP or Protect Duo or ECMO. This is not an easy situation. And I think that also for this hemireperfusion injury, he would be much better off with the MCS. I don't know what Katherine and Manos think.
Yeah, I mean, I think I just applaud you for doing the VGram in this situation. I am not a huge performer of VGrams in this sort of a situation because we do have echo and can save contrast. But when you have that much thrombus in the LAD, I'm immediately going to, do we have an LV thrombus? And, Lorenzo is very lucky. I certainly do not have access to, like, within 5 to 10 minutes on a Sunday, a Sunday morning bedside echo with contrast and things like that. Like, I don't have that. It's me with an ultrasound probe and a tech driving in from home. So, but I think a well-done VGram with a power injector can really answer if you have a mobile apical thrombus. So I would have done the exact same thing in this situation.
Well, I think in our place, a patient like this will go straight to ECMO. I think, you have such low index. It's unclear, it's right, left, but I mean, the filling pressures are extremely high. The oxygenation issues from what I remember before with the patient. And I agree, I think probably put him on ECMO to stabilize them. And then to Lorenzo's point, we need some afterload reduction. So then you might need an Impella. So like a Impella or sometimes a balloon pump. But yeah, I think definitely some support would be required. And an interesting thought that came from the audience, which actually it's a possibility, is about COVID. Sometimes during COVID, we saw these massive amounts of thrombus. I don't know if this patient doesn't seem like he had a history of any issues with infection, but there might be another cause of potentially having the such important clot.
Right. So because of the we have been having a hard time oxygenating him. He was saturating in the 80s, despite FiO2 being on 100. So as to the panel point is he required mechanical support because of the oxygenation issue as well as the shock situation. We did cannulate him for VA ECMO. Definitely his course wasn't very pleasant. He ended up with AKI, a shock liver. He was in the CCU for 27 days, intubated, ended up with tracheostomy, and he developed I think because of the beginning high dose inotrope finger and digit ischemia, ended up with losing a few digits from his hand and a few digits from his toes as well. But eventually was transferred to LTAC, where he was vent weaned, and eventually 3 months after discharge from LTAC, that's 6 months post the index admission, his EF is 40%, and he was mentally functional and neurologically functional.
Wow, that's a big save. And did you ever figure out the cause of it? Did you have like a PFO, any DVT? Did it ever become clear what caused it in the first place?
Not really. I mean, and the problem is a very tragic story because on the day 5 of his hospitalization, he lives with his mom. So his mom came and told us that has been feeling sick because he stopped taking Xanax, because he was taking street Xanax doses to get addicted, but eventually start weaning himself off. But what happened, he came to her and she drove him to emergency room. And she said he was just feeling nauseous, mainly GI symptoms. I don't recall if he has any respiratory symptoms, but he COVID negative, tested in the hospital. On day 5, she stopped coming visiting him, and what we heard from the neighbors or a cousin that she passed away at home. Most likely she had Takotsubo, or I don't know. She passed away anyway. So we have a misconnect, and then he went to LTAC and came back. His cardiac and neural function is as I said, is recovering, but no PFO, and we couldn't tell that missing story of what happened, of what the trigger for this heavy thromboembolic event.
So he didn't have an LV thrombus, right?
No, to your point, yeah, there was an LV thrombus on the echo. I'm sorry, yeah, on the echo I didn't put there, but with contrast, there's a very mural thin layer of thrombus was seen on the echo. It wasn't big enough, yeah.
Yeah, you know what might have happened, Chadi? I think maybe some kind of toxic cardiomyopathy induced by the Xanax or God knows what else that gave him like a massive myocarditis. An LV thrombus developed, and then it embolized into the left main and went all the way down in both coronaries. Because you didn't see any kind of plaque there, right?
At all. I mean, I did IVUS just to make sure I'm not missing anything. And to your point, I think as you see from the LV, he has a Takotsubo phenomenon from the LV. So most likely he had a kind of a stress cardiomyopathy from whatever medication he was taking or drugs he's been taking, as well as myocarditis kind of phenomenon.
Yeah, because he was feeling sick for days and days, and probably he was in this nausea and vomiting was a low output syndrome, and that is the main presentation. And then the ACS was unfortunately just like a complication of that.
And definitely the age 29 kind of persuaded everybody from going straight to the heart.
Yeah, great case, and thanks for sharing it.
Yeah, no, thanks. That was definitely an exciting case. I mean, it's easy for us now to look at it, but doing it on this.
Yeah, thank you so much.
I mean, that's probably, and also being so young. It's one thing if the old 80-year-old comes in with this, but 20-something-year-old, I think the stress of everyone involved is so much higher because everyone obviously wants the younger people to do well given the life expectancy. A couple of comments that came up is about thrombophilia workup. Was there a thrombophilia workup? But as you said, maybe it was just, if it's LV thrombus, that probably explains about what happened there as well.
And for the audience, I didn't show the right side. The right coronary was completely open as dominant RCA. And we know this is the most common, usually thrombosis comes, thromboembolic comes to the right side. But surprisingly, he didn't have anything on the right side.
Wonderful. So Chadi, thanks again. Phenomenal case. Thanks very much for sharing with us. And then we'll move on to Dr. Kunkel. So Katherine, looking forward to seeing your case.
All right. Thank you so much. So I am going to share with you a very emotionally enriching case. When you said my most exciting PCI for the last year, my mind never goes to a good place. So I'll show you something that was a little bit painful for me to go through in the process, and hopefully we can learn something along the way. So this is a 64-year-old gentleman who comes in with a new diagnosis of angina. Here's his home medications. He's on one anti-anginal. And so he has a non-invasive evaluation as an outpatient. He has an abnormal stress test, gets a coronary CTA, and has severe LAD disease as well as intermediate left circumflex and RCA disease and lots of severe calcification. So here's his diagnostic angiogram. And you can see kind of what we're describing as a target-rich environment. So we have, a second obtuse marginal with a high-grade lesion, and obviously what seems like probably the most acute culprit in the mid-LAD. You see there is some proximal LAD disease. We'll come back to that. And here's the right coronary, which looks just fine. He hadn't had an echo, so here's his V-gram, which is pretty unremarkable. And so, now what? So this is, it's a calcified mid-LAD. The calcium isn't all that bad. But, given the diffuse nature of the disease, multivessel PCI, I opted to stage the procedure and come back on another day. So here's the planned PCI in this patient. So, was ultimately able to cross. It was actually a bit difficult to get a microcatheter across, but started ballooning and was able to IVUS. Was able to, open this vessel adequately to pass an IVUS using a Scoreflex balloon, and then performed IVUS. And here you can see some still frames from that IVUS. And so if you start in the bottom right of your corner, you'll see the distal LAD, you'll see our distal landing zone, mid LAD, and then, unfortunately, here's that proximal LAD, and that's what I had planned on leaving behind. And then you can see kind of here's the ostial LAD where, it looked to me like there was, an area that had less than 50% plaque by burden to potentially land a stent and then the left main. And so kind of here's the situation I was in. I said, okay, this is where I'm landing my stent. There's no ambiguity there, but, how far back am I bringing this stent? Are we going to be a more is more or less is more interventional cardiologist today? So am I doing something like that? Am I stenting more back here? Or are we coming the whole way back? And, having done the IVUS, as is often the case by, those of us who do a lot of IVUS guided PCI, I opted for the red line to cover that, lesion that looked quite severe on IVUS. Based on the IVUS, I thought that I had an adequate landing zone in the ostial LAD and that I didn't need to cross back into the left main. So
and then maybe Lorenzo and Chadi, you agree? Would you have done something different? Since again, geographically, it doesn't look that bad. And would you have necessarily done imaging before? Because some people say you can do imaging after you put your stent to check the result. But here, obviously, the imaging did change the strategy completely from the get-go.
I would definitely do the same. Imaging is very critical here. It's very persuading looking at this angiogram. Once you see this critical lesion between the green and the blue, but definitely that doesn't mean that proximally there's no disease. But pre-IVUSing, I always tell the techs, if when I do IVUS after, let's do it before, so it's same catheter. And also it helps you when you advance the catheter, or if you're struggling to get through, that's gonna give you an idea how's your equipment gonna go forward, and if you're going to be able to develop kind of heavy or bigger balloons and stents.
Yeah, I agree. I would also stent from red to blue. Sometimes when it's very clear what plaque modification technique I have to use, for example, atherectomy or shockwave, I would skip the very baseline shot, imaging and run, but I would still do imaging before deciding where to stent, particularly in a case with diffuse disease like this one, because this proximal LAD lesion is intermediate plus. So, you do an IVUS, you find out that you can't just land a stent just before that, and you need to cover up all the way up to the ostium. I think so far I would have done the same as Katherine.
Okay, thank you. So that was the adventure I set myself out on. So after pre-dilating everything with cutting balloons, you can see here's my first stent. Here's another overlapping stent. And as was mentioned, I really was aiming for that ostial LAD, which certainly looked fine angiographically, and I thought looked pretty good on IVUS. Here you can see that result, and I was unhappy with that diagonal. As you can see, it's a very important diagonal, 3 large branches coming after it. You see the os is quite pinched. So here I am post-dilating, a small area of under expansion. I recrossed and did kissing balloons. And that was my result. I did more proximal optimization. I ended up tacking a distal stent distally because I had landed in a bit more plaque than I preferred. Hit that one spot harder with a non-compliant balloon and was ready to give myself a high five when I looked back at that ostial diagonal and was quite disappointed to see that it was, again, you know, quite stenotic. So I don't know kind of what everyone else would do at this point. I opted to go back and do non-compliant kissing balloons, understanding that I may need to end up stenting if I dissected the vessel, but really feeling like, you know, I needed to make a difference in the os of that diagonal.
So just
And then
curious, what
ultimately,
would so what would Lorenzo and Chadi, what would you do for this diagonal?
Well, yeah, at this point, I have to change strategies and descend from what you've done. I mean, even before the first kissing, I think sometimes the angiographic appearance, particularly side branches, is worse than it actually is. So I'm not saying I wouldn't have done anything, but I would have done a pressure wire. Actually, yesterday in the cath lab, we had the same situation on a circumflex after left main provisional stenting into the LAD. I was pretty convinced it would have been negative, but it was a large circumflex. It was ostial pinching, did RFR, turned out 0.87. We did a kissing, and then the RFR improved. So I think physiology has a prominent role in guiding us in our intervention on side branches, and I would have done it here.
well, Lorenzo, thank you for that. We'll come back to that idea in a moment.
Of course, again, it's always easy post hoc to find different plans, but
don't worry.
The CathWorks can help too. If you have a CathWorks, sometimes you can do it and get a sense of what's going on.
But you wouldn't have a case for tonight, Katherine, otherwise. So
yeah, well, this was the bifurcation case that just kept giving. So you know, at this point in time, I decided, for better or worse, that I was done with this diagonal, and so ended up taking these pictures and had some feelings about the circumflex. You know, and kind of all these ideas go through your head. When you're a fellow, they teach you, you know, like side branches always get elliptically deformed when you have plaque shift. It always looks worse in one view than it really is. And so, you know, this is kind of the still frame of the 2 different views of the circumflex. And these are kind of the different options that came to my mind. I don't know if the panel has any strong feelings. I can tell you what I did, which is what Lorenzo had suggested.
Right. I mean, definitely it looks it's foreshortened on the right picture, but the left definitely it's a bit better, maybe 50%. But again, angiography in the era of physiology and imaging, it's you have to do one of those. But I can tell the physiology would answer that question.
Yeah. So, you know, I wished I was happier angiographically, but you know, I trust physiology and was kind of happy with how this physiology looked, and I called it a day at the time. So this was the end of that case, which wasn't the easiest case. So, you know, 124 minutes of sedation, 200 cc's of contrast, and a gray. And so I do my next case, and while I'm in my next case, I get a call from the recovery room that the patient from case number 1 is having nausea, vomiting. Can I get an order from Maalox? I said, sure. Can we also check an EKG? This is the EKG. So, you know, and the patient had also just taken 600 milligrams of Plavix. So, you know, at the time I said, okay, have your Maalox, and we'll go from there. And so, you know, he's fine. And so then I move on to case number 3, and he's better. But during that next case, I get a call. He's vomiting again. Can I get an order for Zofran? And I said, okay. Can I get another EKG while we're at it? And again, really normal EKG. But I went back and I saw the patient between cases, because just I had uneasy feeling about the circumflex despite the normal physiology. And he just didn't look right. He was uncomfortable appearing. He's like, I get this when I take pills on an empty stomach. I just feel really nauseous. And so, I guess the panel can probably guess what I did, which was bring the patient back to the cath lab.
100%.
And,
I mean,
yeah.
we had these situations before between losing the PTY12 inhibitor as well as between knowing the anatomy that you had a pinch diag as well as borderline circ. It's time to take him back.
When was the Plavix given?
Before the case started. So when he got on the table. So 2 hours and 4 minutes before the end of the case. So yeah, in my planned PCIs, I tend to, when they get into the room, I'll give them a load of Plavix before they get on the table.
No, of course. I'm just thinking, yeah, I mean, this was probably a dissection of the circumflex induced by the stent, but EKG was totally normal, both of them. I don't know if he just got upset, stomach upset, and like he said, vomited, and then the absence of P2Y12 inhibition triggered that with a substrate that was facilitating, which is the dissection, probably.
Yeah, I actually didn't have a wire in the circumflex, though certainly that ostial LAD stent could have, shifted or dissected something, but nothing that I had appreciated. I was calling it plaque shift before. So, I've gone back and really looked, but I think, I was misled by the physiology on this case. And as you'll recall, one of the reasons I was hesitant to stent back into the left main initially was because there was an additional circumflex lesion, right? That, after today, I was like, we'll deal with that on another day. That's another problem. So I restored flow, and, you can see here this is just a still from the ostial circ IVUS. And it really, to me, looked like significant plaque shift and, native disease. But again, this is kind of low definition IVUS, so not the highest quality imaging. So, at this point in time, we're doing it all. We're going to have to, now we're committed. We'll be doing, the rest of this gentleman's complete revascularization today. So, get a big balloon, restore flow. I like to use at least a 3.0 to go around the corner to really just move everything out of the way and get some flow back. You can see here, I struggled a little bit with calcium and expansion in that distal lesion, but ultimately was able to get everything dealt with. And so the next question I had was, well, how am I going to deal with the left main, right? Because I know I have some plaque extending into the distal left main. I've already shut down the circumflex once, because this matters in this moment, because where I land this circumflex stent is going to dictate what strategy I'm going to do for my left main stenting. Am I just going to leave the LAD stent where it is, or am I just going to do the whole thing and cover everything? And so I don't know. You may be able to tell that I brought it back a little bit here, because I'll ultimately be doing a crush strategy, but I don't know if anyone else would have done it differently and left the left main alone.
This is like a difficult scenario, because you are committed to provisional from the LAD PCI. At this point, there is no stenting strategy that can give you a good result, because if you just drop a stent in the circumflex as V stenting, you're most likely going to leave some plaque and cover on either the left main, the LAD, or the circumflex. If you cross over into the left main, there is going to be like 1 millimeter or 2 in the polygon of confluence that has no stent on the LAD side. So, there is no easy solution here. Another thought that I want to bring to the attention of the panelists, what about the antiplatelet therapy? Did you give a cannular in this situation with the patient vomiting and the thrombotic event?
I didn't. We don't have, we just don't give a ton of cannular, and I'll be honest, I didn't think of it. I was more viewing this as a mechanical problem than an antiplatelet therapy problem, because I actually don't think he vomited up the pills per nursing. I think it was just kind of some dry spittle sort of stuff. So I didn't, but that's certainly something that I could have done and maybe would do again if I had had this case to do. I would do lots of things different, Lorenzo, if I had this case to do again.
I think that the general role is, regardless if the cause was the vomiting or not, if you have a complex lesion with thrombus involved, more often than not, is before entering the lab. I don't know why I haven't on top of my head, and I often use it in these complex scenarios. And you can just tick that off in your checklist, because you're not going to have a thrombotic event due to an insufficient antiplatelet therapy. Or you might have thrombosis because of low ACT, but in this patient the stakes were high, and he had a thrombotic event. I don't know, Manos and Chadi, what you guys think.
I mean, I'm really concerned when somebody is nauseous and throwing up. I mean, with the Plavix, we know it's absorption, even given before the case. Just to, as you said, you don't want to have nightmare. Check that box. In terms of the technique here, I mean, Katherine, I think you're doing the right thing, and you want to leave nothing. You have already issues with the situation. You want to come up with the best strategy and give him the ultimate result, so you can go to bed at night sleeping well. So in these cases, I would definitely proceed either with DK crush or some mechanism just to cover all the way to the left main and reconstruct the carina, and to avoid any plaque shift or any kind of miss uncovered or geographic miss.
Yeah, no, I think you managed it very well. Now, the one challenge, I think right now there is probably 5-6 millimeters of stent protruding into the left main. So the challenge of that is doing pot might be an issue if you don't have enough stent over there. But actually here, what I would do is similar to yours, is a provisional technique. I think it's sometimes very hard to nail that ostium of the circ if you're trying to nail it and make sure you're there, that V-stenting that Lorenzo mentioned. So trying to go essentially provisional from the left main into the circ, you are likely to have an issue in the LAD, and I think not covering that few millimeters at the top against the carina doesn't matter that much, because there's not much disease there to start with. So doing exactly this provisional with maybe a little more stent in the main and doing a pot there, that might be all that you need. Actually, I would be more concerned for that first obtuse margin that seems to have maybe an ostia lesion and might get pinched with a stent. But again, I think it's managed very well. You got the flow, you moved on. Cangrel O2B3A might have helped, but I think you're doing phenomenal work here.
See it. It's so good to talk with a panel. You see all my problems before I saw them. So yeah, so I deployed the stent, and I had planned at this point in time, I was going to do a DK crush, so to add another stent from the LAD into the left main to just control the entire situation. But of course, now you see this massive obtuse marginal. And again, because my eyes are really on that circumflex, but now you can see that marginal really is filling with TIMI 2 flow, which is quite disappointing. And I've been really struggling with every single bifurcation in this poor man's coronary tree for the last hours, many hours. So I ballooned it with a 2.0. My goal here was to get good flow, TIMI 3 flow. And that was kind of what we got. And so then I kind of moved on with my left main stenting. And you can see here, I'm lining up my stent from the LAD to left main to kind of move on with my crush technique, recross, side main kiss with non-compliant balloons, followed by a pot. And, at this point in time, really wanting to be done with this case. But of course, that marginal is just torturing me. And I, certainly am not looking forward to coming back again for another shutdown side branch. So again, rewired through everything. My goal in this case was I didn't want to, put more metal into this area. So I thought, an undersized semi-compliant balloon for a prolonged inflation, which as I understand what they did back in the days before stents, to restore flow and kind of get us through the end of this case. And here you can see what we look like after that, which, I thought was acceptable going forward. And you can see actually here that diagonal has plumped up nicely that I was concerned about in the beginning. So, this is the end of the case, another 200 of contrast, another 2 hours in the cath lab. I learned a lot of lessons. I think the big thing is I'm pretty fast these days to take someone back to the cath lab for nausea and vomiting, even with an unchanged EKG. I think, sending a patient like this to the unit would have been a mistake, or to a floor bed would have been a mistake. So I think kind of that was my big takeaway. And, you know, I think before this case, I really trusted that IFR of the side branch in my kind of questionable side branch. And I think I trusted a little less after this case. And I think I'll...
Great case. And thanks for being vulnerable and sharing it, Katherine. So I tend to agree with the first three lessons that you mentioned. The fourth one, however, I think if the problem was, I mean, if you have plaque shift, the FFR, RFR, whatever, is going to be positive or negative depending on that. I think what you had was that dissection, and that's why it thrombosed down. So if you, I mean, if anything, you might make a point, I should have imaged the circumflex. I don't know if I would have imaged the circumflex, but I don't think that it was the IFR that betrayed you. I think it was a dissection, not a plaque shift.
Mm-hmm. Yeah,
Couple
I think
questions
I'll
from the
definitely
audience.
be more critical, you know, and look for dissections. But yeah.
So, we have a few questions from the audience before we move on. One is about how the patient was doing. So while all this is happening and the side branches and everything, was the patient okay on the table, or was he not feeling very well? Or
So he was hemodynamically a rock through all of this, which was, you know, the one thing I got off a little bit easy in this case. He had lots of chest pain and nausea on the table, which we kind of got him fairly deeply sedated and to deal with that. But he felt it.
perfect. And again, I mean, I think probably for me, the biggest lesson from this case is the clinical acumen. I think the best move was when you saw the patient not feeling well, as you said, the gut reaction. You don't lose anything to take a diagnostic angiogram. You know, if you are wrong, you didn't lose anything, a few cc's of contrast and an access point. But if you are correct, as it was in this case, you really saved the patient a lot, because imagine you let him go and then at 2 a.m., now he's starting getting hemodynamic issues or other issues, and then it becomes much more challenging to treat. So I think your clinical acumen, looking at the patient and say he needs more attention, I think that's what was the key lesson, and I think very important for everyone attending. Perfect. So again, thanks so much, Katherine. Great case. Due to time, let's move on to last but not least. So Lorenzo, looking forward to your case.
Thanks, Manus. I guess you can see my screen now. So I have to say that this is by any means, this is not the most technically challenging case that I had this year. I think there was it's a combination of clinical satisfaction by how in the end the case and the patient pathway in the healthcare system went, and also some drama during the case, one of the procedures at least. So thanks for allowing me to share it. So this is a 72-year-old East African man with several cardiovascular risk factors. He had some fistulas in the arms because he had ESRD in the past, status post renal transplant now, renal function is normal, and presents at an outside hospital with not clinically very clear picture of altered mental status, hypoglycemia. It was found out with some workup to be suffering from AKI and STEMI, but the patient was completely asymptomatic for chest pain or dyspnea, and he didn't have any heart failure symptom. An echo was done, LVF was borderline normal, and the rest was normal, and a diagnosis of 3-vessel CAD was made. And so, as you can see here, he has a proximal RCA CTO with severe calcium burden here. And then he also has very severely calcified left coronary with, as you can see here, involvement of the ostial circumflex, severe diffuse disease in the first marginal. The second marginal is not a huge vessel, and as you can see here, might be even occluded, but the distal vessel is pretty small. And he also, and the RFR was positive here in the first large OM1. And the LAD disease was not overwhelming, but the RFR was very, very significant, at 0.41. So we have this case now. Syntax score is in the highest tertile, 38. SDS score is 2.2. Honestly, I have to say that I calculated this score for the presentation because the patient was very adamant on not getting CABG and getting PCI instead. So these are the setup shots on the first procedure from transfemoral access that put a bit in better evidence this mid to proximal LAD disease and what we just saw on the left circumflex. So since there was severe calcification, we proceeded with rotational atherectomy, 1.5 burr in the LAD. The vessel proximal was very big. And so we went for a 2.0 burr. You might have argued that in 2023, we could have done shockwave. I think this was done mainly also because we're responsible of training fellows, so we have to expose them to all possible plaque modification technique, and they were a bit low on ROTA, so we did the ROTA here. And as you can see,
a quick question, Lorenzo, maybe to the other panelists, how often do you do ROTA with a 2.0 burr?
Not often.
I don't have ROTA. Usually we do orbital CSI.
Yeah, I think,
Yeah.
I mean, the 2.0 burr is fairly, you know, I think it's a little, I mean, in this case, the vessel is large, so it should be okay. But yeah, it's something that is done infrequently. And I guess the main thing for me is the risk of entrapment. This might be a little more likely to get entrapped than the smaller ones, but I mean, you never know.
Yeah, I agree. I think the decision was driven by what I just mentioned about the fellow training, and I agree. I don't use the 2.0 burr much anymore, but fortunately, this is not what caused the drama. It's the 2.0 burr. This is all good, as you can see here. The angio check was completely normal, and I just put it because then it's not going to be normal anymore. We had the burr open from the LAD, so we do RA on the circumflex and OM1 with a 1.5 burr, and this is just the first passage. Usually the first passage, what I do is a shorter run just to make sure that there is no issue. So I do an angio check afterwards, and surprisingly, the LAD goes down, okay? No reflow or dissection on the LAD. So I was very surprised. It happened maybe once or twice in my career that the side branch goes down after burring on another vessel. It never happened with the ostial LAD. So I thought maybe some kind of embolic phenomenon from some calcium. It's true there might be some dissection of the circumflex there. But anyway, the patient that was completely asymptomatic before becomes hypertensive, chest pain, ST elevation, he becomes agitated. We have to insert an impella emergently. He had some valve calcifications, valve sclerosis only in the aortic valve, but these did not allow the impella to glide through the valve easily. So we probably interfere with the aortic valve opening. The patient went into PEA arrest, coded, who was resuscitated after 10 minutes of CPR. And you can see here we have still very slow flow in the LAD. And so I thought initially it was no reflow, so I put a dual lumen catheter in the LAD, injected 100 micrograms of intracoronary epinephrine. Nothing changed. Then I said, differential diagnosis most likely cause at this point is dissection. So I ballooned, and in fact the vessel came back with the vigorous TIMI3 flow immediately. So it was probably a dissection.
So Lorenzo, can I ask you a question? So once you lost the flow, then how difficult was the rewiring? And then are you concerned when this happens that you've rotablated the LAD? Could you go subintimal and then, balloon it or make it worse potentially?
Yeah, well, so the first thing, if I remember correctly, I had to pull the guide out and put the impella. So I lost everything because I had to put the impella in. I only had one axis. So then I think I got a second axis, and then this is from a second femoral axis. So I had to rewire, as you pointed out. There was no difficulty whatsoever, but there was I just went in with no microcatheter and a run-through wire. The wire went fine, and then I don't remember. I didn't IVUS at the moment, but the wire moved very easily, and I even engaged the septals. So I was sure I was in the true lumen. But yeah, it's a fair point, because if it was a big dissection, could have been very hard to rewire.
So Lorenzo, do you think the impella and the shock that helps the flow, or is it the epinephrine that you gave, or a combination of both?
So the patient came back with the impella because he was, with very low blood pressure after the 10 minutes of code. I think in general, if it's a no reflow, the impella helps a lot. Still, the LAD went down, so the shock was, the impella was instrumental. The epinephrine did not do anything. The vessel did not come back, and the pressure remained more, increased transiently, but then went back to, soft blood pressure until I got this open. So we just sent the LAD into the left main. We optimize it. We pot it. We unfortunately did not give a lot of contrast. 120 milliliters. Fluoroscopy time was 25 minutes. The patient was extubated the next day. Impella was removed the next day. Patient was fortunately discharged 7 days later. As you can see on the right side of the panel, the IBUS at the end of the procedure was good. So at this point, we had to complete a revascularization.
Lorenzo, I see
yes.
the ostial circle looks weird. It reminds me of Catherine's case, but I guess fortunately you did not have an issue here, right?
No, I think that when there is so much calcium, it might look funky, but it rarely goes down. And anyway, I decided it was very clear in my mind. We're not going to do, when you have a complication, you should just try to get the patient off the table in a safe way. This is stable disease. If it closes down, we will have a good reason to go in again. But after this emotionally enriching experience, the goal is just to cool off. And in fact, it paid off because we brought him back 18 days later. Everything is exactly the same as we left it. So again, transfemoral, anticipating a lot of difficulty with support and advancing gear. So the plan was at this point, since we had a stent in the left main, of course, to try to do balloon-based plaque modification with IVL into the circumflex O and OM1. So we created some room with shockwave. 2O and C does not expand. There's a tortuosity at the OM1 ostium. 360 degrees of calcium is why we cannot get stuff in. And so the balloon, of course, is underexpanded. A wall ring would not cross. Scrophula would barely get in. And due to the tortuosity, we just stop. So at that point, I even tried balloon anchoring the LAD stent because the LVF was normal. The patient was enduring it pretty nicely to try to push forcefully the shockwave through the ostium of the OM1. You can see 8 French lung sheath. Regardless, the shockwave cannot go in. Of note, fun fact, the patient also was very adamant. He didn't want rotational atherectomy anymore because he was traumatized, and rightfully so. And I was, of course, a bit wary of using Rhoda. So then we opened the stent strut in the left main, brought a guide liner coast through the ostium of the circumflex to deliver shockwave. But the shockwave cannot go any further than that. And the vessel, as you can see, is much more calcified even further down. And the shockwave is not expanding. So at this point, regardless of
how many shocks did you give? How many pulses did you give?
I don't remember, but since I could not bring it further down, even I don't know if I tried a new shockwave balloon, but there was so much more area of calcium that I had to treat, honestly. So you cannot make a point, you just drop a stent there, because there was a lot of plaque distally. So I needed more plaque modification. And so, I said, we're going to bring a guide liner coast through the stent strut, protect the stent, and just drill it with the rotablator, 1.5 burr. And usually 99.9% of the time I use Dynaglide to go up, but this the burr with Dynaglide interacts with the push rod of the guide extension. So I just went manually and then activated Dyna when I was complete inside the guide extension. Manos and the others, do you have any insight here? Anything differently at this point?
Well, I think the guide liner course is a very useful one. I think it has this coiting and delivers very well through these very challenging angles. So I think that's a great idea. And I agree with you. I would not activate it inside the guide catheter. The other option here, obviously you had to do something dramatic, is to try the very high pressure balloon maybe, but you might have had similar challenges with delivery. It's not as deliverable either. So I don't know, Chadi, you wanted to say something?
Yeah, for the Rota, again, I don't have experience, but in these tortuous cases, you want to advance a guide liner to avoid as much turns in the vessel, especially in the OM, because an orbital atherectomy, as you know, it has the highest rate for perforation or dissection because of the way it's spinning. But usually advancing a guideliner close enough to the lesion, number one, help you with delivery. Two, minimize how it's going to be turning on and ejecting out of the guide. The closer you are in the lesion is safer.
I like Lorenzo's approach of trying to essentially stand on your head to avoid having to do this is exactly what I would have done. I OM1 specifically, I use a lot of wiggle wire there. Like this is a case where I think pulling out a wiggle wire can sometimes change the game a little bit. It's not a wire that I used a ton, but kind of as an attending have really adopted. And I think OM1 with calcium is a great spot.
Yeah, there was someone who brought up why not laser? Yeah, we thought about that. Laser, I think it's good when you have some like focal spot, a fibrotic lesion, but it would have not delivered probably, and I don't think it would have been able to actually modify all the calcium that it needed. It was a very, very long segment, and I don't think it would have made a difference. So that's why I went for Rhoda. So
Lorenzo, you think next you can go with the shock? You think when you open the pathway, you can go with the shockwave again?
yes, in fact, to your point, balloons now cross and expand very easily, and I was able. I think I used the shockwave afterwards because I still had some shocks. Then, long story short, we dropped some stents in the OM1, put another one at the circumflex ostium with a tap with the old left main stent, kiss and pot. And then we have a decent final result with low contrast volume. So anything weird? Do you see anything weird here, guys? Manus?
So there's some distal to the distal edge of the stent into that OM. It looks like a big step down. Now it could just be the size of the vessel, but just looks a little funny there.
Mm-hmm. The others?
How about the oxtial stents, LAD and circ? I cannot see it very well.
Mm-hmm.
You didn't put you didn't extend to
one.
the left main stent, right? You just did
Yeah, what was the technique you used for the ostium? It looks like there's a short stent into the main.
Yeah, it looks like you have longitudinal compression.
Bingo. Yeah, I did tap with the old stent, but you see there's no more left main stent.
Yeah.
I mean, it became like a kind of a crushed V. And in fact, I used, as I always do, everything at the end. And there was a longitudinal stent deformation in the left main. It's not too bad on IVUS. The MSA is huge. So it would have involved like a complex stenting with putting yet another layer of metal. So I decided to leave it alone. The ostial circumflex had a reasonable MSA for a circumflex. Also, this person was of a shorter stature, so it was all these MSA's threshold are not indexed. I felt that 5.6 was enough, but yeah, you're right, Katherine. There was a longitudinal stent deformation in the left main, and that we decided to leave alone because it looked reasonable. The patient came back almost
I think it was the guide extension, right? It was the guide extension causing this, right?
In fact, when I was preparing the case, I went back to the images, and you can see that it was the moment when we went with the guideliner coast or I don't know if it was the guideliner coast or sometimes that we tried to push stuff and vigorously into the circumflex, and the guide or guide extension damaged the left main stent. Brought the patient back for 27 days later. Radial bifemoral setup, the CT of the RCA short taper stump, distal vessel lights up to the proximal to mid portion. There are some collaterals. This is real-time wiring. Turnpike spiral and gladius mongo gets easily through into a side branch. We bring the microcatheter through. We redirect with a workhorse wire. We're able to wire the distal RCA. Since we had the true-to-true crossing, we did orbital atherectomy here, a few passages, and then we stented with a couple of stents all the way up to the ostium. We also flashed it to make sure that the stent was well flared at the ostium. And this is the final result. MSA is nice, 120 milliliters of contrast. And so just some final consideration. Oh yeah, so here we checked again the left coronary, and everything was like we left it the last time. It looks like a bit weird here, but so far the result was holding. Of course, it was just 1 month follow-up. Total radiation over 2 months was less than 1 gray, thanks to our X-ray system, but also because the patient was very like small. It was like 147, I think, in height, and 147 meters, and like 56 kilos. No PCI resulted in AKI. We only had that no reflow versus dissection as a complication during the first case. There was a high adrenaline environment because it required impel insertion due to cardiogenic shock and cardiac arrest. The patient is doing well, a 3-month follow-up that he just completed. And these are the discussion points. I leave them there for all the panel, because I think I learned a lot from this case. It brings up a lot of points that deserve discussion. So yeah, let's go and discuss it.
Yeah, thanks, Lorenzo. I think, again, many lessons, as you say, and I think most people would have said, the RCA is going to be the tough one and the risk there, but actually it was not. I think another lesson is that atherectomy does carry risks. There's no question about it. And in this case, it was kind of unusual, as you said, to have the main vessel shut down. But I suspect it wasn't the atherectomy, the diagonal. I think it might have been that during the original run in the LAD, it got disrupted. And then once you lost wire, maybe the vessel collapsed. And that's one of the downsides, I guess, of having to remove the wire to do the atherectomy on the side branch. But Katherine, Chadi, any other thoughts?
Yeah, the first question, Azzalini, I think it's, I wouldn't start with the RCA first, because I think, I would start with the donor vessel. And then again, it's, I think that's the main territory of the myocardium that's involved. And I think this most likely, I'm assuming this is the he's symptomatic from this compared to the CTO area. But definitely in terms of the technique, as you said, you have to be savvy with all the tools and equipment for severely calcified lesion. Shockwave, definitely it's taking momentum, but they show a nice illustration of sometimes deliverability is a problem in these bulky, semi-bulky balloons. And rota shock is kind of an approach which is, often used in these situations, especially in tortuous vessel like OM and circumflex.
Yeah, I think being facile and quick on your feet, this is just like a complete showcase of that. I feel like I watch so many cases, and I would say this could have all been avoided with drilling up front. But I think in this case, kind of the first challenge was from drilling, and the second challenge was from trying to do too many things before drilling. So I think it just reinforces one more time that if you're going to take on these cases and do them well, like obviously Lorenzo has expertly shown, you just have to be ready for kind of whatever comes, because that's kind of what we encounter in this business.
Wonderful. And on this note, again, I'd like to thank, we're a few minutes past 9 o'clock or 10 o'clock Eastern time. Excellent cases, lots of learning in this case. Trust your gut, be ready for tackling the unpredictable, the things that don't happen. And that can help optimize the outcomes of the patient, and also having the hemodynamic support available, I think that can play a huge role both in the first case, but also in the last case as well. I would like to thank one more time our sponsors, Abbott, Medtronic, and Shockwave, and thank again Chadi and Katherine and Lorenzo. Thank you so much, and thank all the viewers for joining us tonight. Thank you so much.
Thank you, Manos.
Thank you for having us.
Thanks, everyone.